Thank you for inviting me. I've been asked to talk about our rabies work in Thailand, but first I'd like to show you that rabies is an extraordinary virus. This man was bitten by a dog in the street a few weeks previously. He now has rabies encephalitis. He's very thirsty, he tries to drink, but he's afraid to swallow. The disease begins with vague prodromal symptoms of fever and agitation and a variety of others. The only specific symptom is paresthesia at the site of the bite, and this can be itching, pain, or numbness. This leads to prostration and hypersalivation, and there are two clinical forms of rabies, furious and paralytic or dumb rabies. Furious rabies is characterized by hydrophobic spasms, which are provoked by drinking or a draught of air. They're reflex, forceful, jerky spasms of the muscles of inspiration, rather like when you're about to sneeze. But it's associated with an inexplicable feeling of terror. And this might progress to convulsions, cardiac or respiratory arrest, and might end in opisthotonos. But in between these spasms, there are lucid intervals when the patient is conscious and aware, maybe aware of what's going on. There are cranial nerve lesions and, surprisingly, diabetes insipidus. So if you have a patient with undiagnosed encephalitis who suddenly has a massive diuresis, think of rabies. There's autonomic dysfunction, hypersalivation, lacrimation, loss of temperature and blood pressure control, and this progresses to coma and then death within 1 or 2 weeks. Paralytic rabies is quite different. It's an ascending paralysis with loss of tendon reflexes and, again, autonomic dysfunction. The paralysis ascends to involve the muscles of respiration and the patient dies, but they may survive 3 or 4 weeks even without specialist care. Nearly all human rabies deaths are due to dog-transmitted virus, and this is in Asia and Africa. And the dogs might appear wild and furious, or they might have a paralytic disease. The cycle of infection occurs within the dog species with occasional transmission to domestic mammals or humans. But there's also sylvatic or wildlife rabies with an identifiable strain of virus in different mammals, and these are reservoir species which vary around the world. Although in Africa the dog is the dominant reservoir species, the main wildlife reservoir which is likely to infect humans is the black-backed jackal in southern Africa. In Europe, the dominant reservoir species is the red fox, and the whole of Western Europe was cleared of fox rabies by oral vaccination of the foxes, but it persists in the East. These are the data for 2018, over 4,500 reports of animals rabid. But then you see the COVID pandemic effect with decreasing numbers reported each year since then. In 2020, Russia, which used to report the highest number of cases, stopped reporting altogether. And of the 900 reported last year, over 700 were from the Ukraine. In the USA, it's skunks, raccoons, and foxes, which are the terrestrial reservoir species, but their main problem is rabies in insectivorous bats. And these are the greatest cause of indigenous rabies in the United States, about 2 patients a year. There's vampire bat rabies. These normally feed on cattle and infect them with economic loss. They occur in the northern part of Central of South America, the Amazonian region. They also bite people at night, leaving small, painless lesions which might go unnoticed. But if you sleep under a mosquito net, you'll be all right. There is bat rabies and insectivorous bats in Europe, in every country where it has been looked for thoroughly. In Australia, they have an Australian bat lyssavirus, usually in these fruit bats which hang in flocks in the trees. And this virus has been responsible for a rabies-like illness and death in 3 people. An example of bat rabies in humans is 2019 in Vancouver Island in Canada. A young man was driving in broad daylight, pulled over to the side of the road, and a bat flew against his hand. There was no visible lesion. He did nothing about it, but 6 weeks later, he died of rabies. Now, bats don't normally fly around in daylight, and they are very good at avoiding bumping into people. So this bat was behaving abnormally, and abnormal behavior in rabies reservoir species is a warning that it might be rabid. This is the family tree of rabies and rabies-related lyssaviruses known to cause human clinical rabies. They're all of the lyssavirus genus, a member of the Rhabdoviridae family, these bullet-shaped viruses. Classical rabies is the species 1, which is the cause of infection of dogs and all other terrestrial mammal reservoir species. It also includes all bat viruses in the Americas. In the rest of the world, there are bat lyssaviruses, and with different species in different continents and parts of the world. All the rabies vaccines used are raised against the species 1, classical rabies, and the neutralization of the bat lyssaviruses might not be so good. Human rabies can also be transmitted by organ or tissue transplantation, here a cornea, but it can be kidney, liver, heart, lung, even a segment of artery has transmitted rabies to a recipient. Rabies infection usually occurs when virus in the saliva of a rabid animal is inoculated under the skin. It enters the tissues and then a nerve ending and ascends within the axon by retrograde axonal transport towards the spinal cord. This is during the long incubation period, usually 1 to 3 months, but is very variable. The virus ascends to the brain and the clinical disease begins. The virus has by this time descended back down nerves to infect many different organs, including the salivary gland and the skin. The best way to make the diagnosis of rabies encephalitis during life is to take a full thickness skin punch biopsy from a hairy area, usually the nape of the neck, and make a frozen section and vertical view through the dermis, and here you see a shaft of hair follicle, and the bright fluorescence is rabies labeling nerve twiglets round the base of the hair follicle. This is immediately characteristic and diagnostic, and you can make the diagnosis in the same day, but it's not done in very many places. You can also make the diagnosis by PCR, but usually on saliva, but a variety of other samples too. Virus isolation is ideal, but it's rarely done. The presence of neutralizing antibody in an unvaccinated patient is immediately diagnostic, but the presence of very high levels of neutralizing antibody in the CSF has been used to make the diagnosis. You need to repeat the samples daily until you get some diagnosis. Post-mortem, the best sample to make or confirm the diagnosis is to take a brain needle necropsy through the inner canthus of the eye. It leaves no mark on the body and stained with immunofluorescence. This is an H&E stain of a brain smear. This is a neuron and the nucleus, and here you see a cytoplasmic inclusion body, the classical Negri body of rabies, which is a factory for manufacturing rabies antigens. The question I'm always asked is, do patients recover from rabies? Well, the bottom line is that 2 patients have recovered fully to lead a normal life, but many patients have been given intensive care and have been reported as survivors, but they have long-term sequelae from which they never recover. They are dependent for life. In Thailand, we attempted therapy of rabies encephalitis using intraventricular alpha interferon and ribavirin. The patients developed many complications and the treatment not successful. But after death, the titer of rabies virus in the brain was very high. The rabies is 100% fatal in symptomatic patients who've been infected by dogs. If they have had some vaccine, there is a remote chance of prolonging life with intensive care, but always with neurological sequelae. There's no effective treatment. The much vaunted Milwaukee protocol has been tried over many years and in several patients without any success. So after confirming the diagnosis, consider using intensive care if the patient has been infected by American insectivorous bat rabies. It seems to be less pathogenic in man. The 2 patients who recovered had both been bitten by these bats. Or if antibody is present very early on in the illness, then it's worth trying intensive care. Otherwise, compassionate palliative care is the best management, and that means actively treating the symptoms to relieve the suffering. You can offer post-exposure vaccination to contacts, but there's no documented case of transmission of rabies from a patient to a carer. The good news is that rabies vaccination is very successful. After contact with a possibly rabid mammal, the treatment is post-exposure vaccination and maybe immunoglobulin. This is very effective if it's given promptly and correctly, but delay often occurs and incomplete vaccination is not unusual, and it's unreliable. Anyone who's had pre-exposure vaccination and then has exposure to a possibly rabid mammal only needs booster vaccination, and no deaths have been reported. And this 100% success of vaccination is unique among all vaccines. So pre-exposure rabies vaccination is clearly a good thing. It should be given to everyone at risk, obviously laboratory workers and people who handle animals, vets, wildlife workers, bat handlers, zoo staff, even in the UK. Hospital staff likely to come into contact with rabies patients, I've said it's a very low risk, but it overcomes quite justified fear. And most important for this audience, travellers to or residents of dog rabies enzootic areas, that is Asia or Africa. So if you're thinking of going to these areas in the foreseeable future, think about getting your pre-exposure vaccination now. There are 3 rabies vaccines pre-qualified by WHO. The original human diploid cell vaccine, a purified vero cell vaccine, Vero-Rab, which is only 0.5 ml in a vial, and a chick embryo cell vaccine, Rabipure. In the States, it's called Rabavert. The name varies around the world. But other tissue culture vaccines are produced in India, China, and Russia, but their quality is unknown. The pre-exposure vaccination course recommended in the UK is 3 doses, 1 on day 0, 1 on day 7, and 1 on day 21 to 28. I think it's best to delay it till 28. But the timing is not important. It can be weeks or even months between the doses. As long as 3 doses have been given, it means that it will guarantee 100% seroconversion. So everyone must keep a record of their immunization. The UK also recommends an alternative accelerated regimen of intramuscular doses on days 0, 3, and 7, and at 1 year. The vaccine is usually given intramuscularly, but for economy, it can be used intradermally. To give intradermal injection, use a Mantoux syringe and inject 0.1 ml horizontally into the dermis and inject to raise a papule with a peau d'orange appearance. Many patients who go to a travel clinic asking for vaccination don't leave enough time for a full course of vaccine. But having had any vaccine in the past is an immunological advantage if you're exposed to rabies in the future. So always give at least 1 dose of vaccine. They can complete the course later. The cost is prohibitive. In the States, it costs $200 a vial. It's less in Asia and Africa. And in the UK, it's about £40 a dose. So to economize, you can give 0.1 ml intradermally and share the vial of vaccine between a group on this must be the same day and discard the ampoule at the end of the day. Strict aseptic precautions must be used, of course, a new syringe and needle for each person. But the route of intradermal rabies vaccination is off-label globally, although it's been recommended by the WHO. The UK Green Book says that it is permitted to use it if the person giving it has experience of intradermal injection. If you're going into the wilderness, you can take a vial of vaccine which is lyophilized and stable at tropical ambient temperatures for about a month. And if anyone is exposed to rabies, you give them the whole vial of vaccine intradermally using the deltoids in either the thighs or the suprascapular. If more than 1 person is exposed, then you share the vial between them. Most people who've had a 3-dose course don't need any boosters, but if the risk of exposure is going to continue for people who are living in an endemic zone or are frequent visitors, an optional booster at 1 or 2 years enhances and prolongs the immune response. But people who are going to have access to vaccine if they are exposed don't need any boosters. And people going to high-risk areas with uncertain access to vaccine should consider a booster dose if their previous last dose was many years ago. But it's always best to have a neutralizing antibody test first and then only have the vaccine if it's a low level. But everyone must know that if they have exposure to a possibly rabid mammal in the future, they must always have booster vaccination. This stoical little boy was bitten by a proven rabid dog in Bangkok. He has multiple facial lesions and is at severe risk of rabies. The risk of rabies has been categorized by the WHO. Just touching or feeding animals or licks on intact skin is no risk of rabies and no treatments indicated, but you can always encourage pre-exposure vaccination. Minor scratches or abrasions without bleeding are a low risk and vaccine is indicated. Bites through the skin or scratches or licks on broken skin or mucous membrane contact or exposure to bats are all high risk, and vaccine and immune globulin should be given. But bites on the head, neck, and hands are a severe risk. They are heavily innervated areas, and so the virus might enter a nerve ending more easily. These should be treated as an emergency with vaccine and immune globulin within 12 hours. Post-exposure vaccination consists of 3 parts: wound care, passive and active immunization. And wound care is very important. It should be a public health message to wash with soap immediately after the bite. You should in fact scrub with soap or detergent and water for several minutes, preferably under a running tap. You can give a virucidal agent. Povidone iodine is best. Ethanol is painful. Other antiseptics are less effective. Avoid or delay suturing. You might inoculate the virus deeper into a wound. And don't forget tetanus. Rabies immune globulin is a ready-made antibody which is injected into the wound to neutralize the virus before it can enter a nerve ending. It's used in the interval between the start of a vaccine course and about a week later, when endogenous vaccine-induced antibody is produced. So if the patient has already had vaccine for more than 7 days, RIG is not needed. The dose is 20 international units per kilo of human rabies immune globulin, and it should all be infiltrated into and around the wound if that's possible. If it's a finger bite or something, then you can inject any remainder intramuscularly. But this isn't available in very many countries, most of Africa and large parts of Asia, especially rural areas. The post-exposure vaccine regimens recommended in the UK are a 4-dose regimen intramuscularly, 1 on day 0, 1 on day 3, and 1 7 and 21. There's an alternative regimen recommended by WHO, a Zagreb 211 regimen with 2 IM doses on day 0, 1 in each deltoid, 1 on day 7, and 1 on day 21. They both use the same amount of vaccine, but the Zagreb one has only 3 visits, and so it's preferred in some countries, especially on the continent. Or you can give the vaccine intradermally. And intradermal post-exposure rabies vaccination was begun at the Queen Sawappa Memorial Institute of the Thai Red Cross Society in Bangkok. In 1979, the The usual treatment was simple sheep brain vaccine, and a milky homogenate was injected in doses of 2 or 5 mils daily over the anterior abdominal wall, and neurological reactions occurred. To avoid having this, the patients bought the biting animal to be tested the same day, and they only had to have the vaccine if it was possible, and they'd wait around for the result. At this time, human diploid cell vaccine had been created and was being used in the West, but it was far too expensive to use here. So we adopted the multi-site intradermal injection technique pioneered by Dr. David Tyrrell at the CRC at Northwick Park. The idea is to inject several intradermal injections to rapidly induce high levels of neutralizing antibody and yet use less vaccine. So we did 2 dose-finding pilot studies, varying the amount of vaccine per visit, the timing of the doses, and the effect of adjuvant. The result was that the most immunogenic regimen and rapidly immunogenic was an 8-site intradermal regimen, using a whole vial of vaccine on the first day, divided into 8 intradermal sites, 0.1 ml per site, 4 intradermal injections on day 7 and 1 on day 28. The sites chosen for injection are the deltoids, thighs, suprascapular, and anterior abdominal wall. The rationale being that they all drain to different groups of lymph nodes, and therefore the generation of antibody might be more rapid. Then we did the first randomized controlled trial of post-exposure rabies vaccination, and in patients bitten by proven rabid animals. We compared the 8-site intradermal regimen with the standard at the time, the Semple vaccine. The patients were divided into 2 groups of mild and severe exposure according to their category, their method of categorization at the time. The patients given the patients with severe exposure were given rabies immunoglobulin as well. Now here you see the results. The human diploid cell vaccine, 8-site with immunoglobulin, and Semple with immunoglobulin here. The neutralizing antibody level was significantly higher with the 8-site regimen on every occasion from 7 days to a year. Meanwhile, a Thai group at the same institute had produced another intradermal rabies vaccination schedule using the then newly developed Virocell vaccine, which has 0.5 ml in a vial. They gave 2 intradermal injections on days 0, 3, and 7, and 1 on day 28. They gave equivalent doses depending on the vaccine. So for a 0.5 ml vial, it was 0.1 ml per site. That's using half a vial on each occasion. For the Chikungunya cell vaccine, 1 ml, that's Rabipure, it's 0.2 mils per intradermal site. And if it's difficult to inject 0.2 at one site, then you just withdraw the needle and give the remainder at an adjacent site. An Indian group did a comparison of the 2-site and the 8-site regimens using the Rabipure, the Chikungunya cell vaccine, and the neutralizing antibody level for the 8th site was significantly higher on every occasion from day 7 to 1 year. Both regimens used the same total amount of vaccine, and the only difference between them was that the large dose given on day 0, the whole vial of the 8th site, was divided into 2 on days 0 and day 3 in the 2-site regimen. This shows the importance of having a large dose on day 0. But using half-mil vaccine was not feasible with the 8-site regimen. So we halved the number of sites and doubled the dose per site. So it became the 4-site intradermal 1-month regimen of a whole vial still in 4 sites, half a vial in 2 sites on day 7 and 1 ID injection on day 28, and equivalent doses we used, 0.1 mil or 0.2. We did a trial to see if the difference in the number of sites used affect the immunogenicity, and the result was that it doesn't, it's equivalent. Then the WHO announced that all rabies vaccines given intradermally should be 0.1 mil with any vaccine. The effect was to halve the dose given with 1 mil vaccine. So instead of giving half a vial in a visit, you're giving about a fifth. And as a result, the countries using this regimen in large clinics in Asia demanded higher potency vaccine for intradermal use. The WHO latest recommendations 2018 are rather confusing, and I have selected some of their intradermal post-exposure regimens. Their principal regimen is a 1-week IPC, that's Institut Pasteur Cambodge. 2-site intradermal injections on days 0, 3, and 7. Alternative one is to do the same thing with an extra dose on day 28, which is the original Thai Red Cross regimen. And they also recommend the 4-site 1 month, which is 4 intradermal injections on day 0, 2 on day 7, and 1 on day 28. And this is the only regimen which has equivalent doses, whatever the vaccine. And it's very economical and has minimal vial sharing. The 8-site regimen was recommended by WHO in 1997 and used for several years clinically in Asia, especially Thailand and Philippines. And so the clinical effectiveness of the vaccine during those years is also applicable to the routine use. In fact, it was recommended for very severe bites. It's at least as immunogenic as the Thai Red Cross regimen, and it's important that there's no vaccine wastage on the first day, so it can be started anywhere. The 2-site regimen, which has been in use for many years, has never been able to be used in rural areas because of the vaccine wastage. But if you're using a whole vial on the first day, you can start it anywhere in small clinics. And then you have a week to find the next dose. There's always concern about the ability to give accurate intradermal injections, but accidental subcutaneous injection shouldn't matter with this 4-site regimen, because half the dose is immunogenic in trial conditions and you're giving a large amount of vaccine, a whole dose. Vaccine must never be wasted. So if a patient comes on day 7 and there's no one to share the vial of vaccine, it can be used as pre-exposure immunization immediately for anyone in the vicinity, especially for relatives if they have to pay. Well, the WHO has most recently recommended a 1-week post-exposure regimen, the 2-site. So the next logical thing is to have a 2-visit 4-site 1-week regimen, using a whole vial of vaccine on the first day and half a vial on day 7. By day 14, all patients have seroconverted, which is the WHO definition of an acceptable post-exposure regimen. Anyone who's had a full course of vaccine in the past and is then exposed to a possibly rabid mammal needs booster vaccination. The usual regimen is a 2-dose intramuscular regimen, one on day 0, one on day 3. But for many years, the WHO has also recommended a single-day 4-site intradermal regimen. So according to the WHO, it's either a full vial of vaccine, if it's ViroRab, or if you're using a 1 ml vaccine, it's half a vial. But vaccine must not be wasted. And if you can't use the rest of the vial immediately or the same day, then give the whole vial intradermally immediately. And this is safer, especially if it's a rural area or something where there's not much experience in ID use. And the sites of injection are the deltoids and thighs or suprascapular, whichever is more convenient. So I think there could be a radical change to the method of intradermal rabies post-exposure prophylaxis. Anyone who's had exposure to a possibly rabid mammal gets a whole vial of vaccine immediately in 4 intradermal sites. And this is equivalent to the booster post-exposure vaccination. If they've never had vaccine before, they have 2 intradermal injections on day 7. If they are immunosuppressed, have HIV, or you want to comply with the WHO regulations, you give them a single site also on day 28. This is the most economical method and with minimal vial sharing and minimal wastage of vaccine. I hope that it will be taken on. But if you really want to get rid of human rabies deaths, then vaccinate the dogs. This dog vaccinator in Bangladesh has the complete kit. He's got dog biscuits to attract the dogs, a net, some vaccine, and a dye spray to mark the dog afterwards. Mass dog vaccination can be very successful with increasing levels of vaccination coverage over several years. This is in Sri Lanka. The incidence of human rabies comes down dramatically, and this has been shown in other areas too. So to summarize, dog rabies virus causes 99% of human rabies deaths, and the mortality is 100% in symptomatic patients infected by dog virus. The combination of pre and post-exposure vaccination has proved 100% successful in preventing human disease. And bat bites are a risk of lyssavirus infection globally. There's no effective treatment against rabies, but American insectivorous bat viruses seem to be less pathogenic in man. Intensive care treatment may be appropriate if they've been infected by a bat in the Americas or if antibody is present very early. Otherwise, compassionate palliative care is the best management of the encephalitis in man. If you want to know more, look at the Oxford Textbook of Medicine, the latest edition, 2020 6th edition, which you can find in the Oxford Library online. And don't forget, if you're going to go to Asia or Africa or parts of South America within the foreseeable future, please get your rabies vaccine soon. Thank you and goodbye.